Hello, welcome to our course-free public webinar again. This is Jolie. Last time we have a wonderful speech with Dr. Ashraf, and many dentist friends make a feedback for me, such as the Philippines and Romania, and many dentists from all over the world to make a good feedback. Said last time the course really very useful. So it's great that we have the chance to invite so many professors to share their good technology and good experience for our dentist friend. And this time, the same we have our topic is the management of the difficult root canal attainment. So this is, I think many dentists, this is a difficult point to settle the problem when during the clinic to meet the patient, to meet this difficult root canal. It's very headache. So this time we hope after this course you can settle this problem. And this time we have a special invite our agents in Egypt to talking about something about Asian market and introduce our professor this time. Before we invite, we let me to take some 2 minutes to talking about our course of free public webinar, how to get the certificate. So let me to show for you for this. Join our course of free webinar, public webinar. We can get the supply the certificate for our dentist. So first, you need to like our course of page, and then you need to comment during the course here during the course, and then at last, after the course finish, I will give you a link in the comments. You can fill this link within 5 hours after the course. Then about 5 days, we will send you our certificate. Like this is certificate for you. So if our dentist friend want to get our course training course certificate, please fill this link. So now it's time for invite our friend from MCS. Wait a minute. Hello, Dr. Sarah.
Hello, Julie. Hello, everyone.
This time, nice to invite you to talk with us to come this live time for our free webinar.
Thank you, Julie. Really, it's my pleasure to join you in this webinar. Of course, we are MCS, the agent for COXO in Egypt. We are agent for almost 10 years now for COXO, from 2010. So it's a long journey together.
Very good.
Yes, it's very good journey. We are the sole agent now for COXO handpieces in Egypt, and we have many endomotors also, like C-Smart 1, C-Smart 1 Pro, C-Smart Mini EP, C-Smart Mini Echo, and also implant motors. And now we have also the C-Clear dental microscope. We are here in Egypt now. So we hope that our friends and our customers can take a look at our online store to see all the products from COXO that we have.
Yeah, later you can ask your colleague to comment your link in our comment.
Yes, of course.
The dentist can see your company. Okay, so now let me to begin our lottery time. It's time for you to choose. Last time our course our free webinar, we will supply a free one-piece LED handpiece. So this time it's great to invite you to help us to choose the lucky person.
Yay!
Yeah, so let me try again. Okay. So this is our LED handpiece, cultural LED handpiece. You use the Japan bearing, and then inside have the generator, so it can automatically make out the line. So let's begin. Dr. Sarah, are you ready?
Yes, I'm ready. I'm excited.
Okay. So wait, I'm waiting for you to choose.
One, two, three.
Okay. Oh, this.
Okay. Dr. Chur Jumo. Congratulations, Dr. Chur.
Congratulations. Okay, so please wait for our colleague will contact you. So this course, the same we will have the webinar free product to free gift for our dentist again. So welcome to join with us. So now it's for time to help me to introduce about this course and with our professor this time.
Yes, this time we are glad and honored to invite Dr. Abdulrahman Al Khuli from Egypt. Hello, Dr. Abdulrahman. Dr. Abdulrahman is a teaching assistant in the Department of Endodontics at Faculty of Dentistry, Suez Canal University. And he is also a Silver Board in Excellence in Endodontics. Welcome, Dr. Abdulrahman.
Welcome, welcome. Okay, hello.
Hello. Hello, Dr. Sarah. Hello, Julie.
Hello. Hello,
Yeah,
Dr. Abdulrahman. Nice to have
Hello.
you.
Yes, me
yeah,
too.
nice to hear everyone here.
Yeah, me too. Thanks, Julie. Thanks, Dr. Sarah. Okay, let's share my presentation.
First, I think you and Dr. Sarah both from Egypt. You can talking about something about the Egypt situation of the dentist now.
Yeah.
Yes, now after COVID-19 situation,
Yeah.
so the Egyptian market and the Egyptian dentists are trying to come back to their work. And now I think that during COVID-19,
Mm-hmm.
it was a good opportunity for dentists to learn more and to gain more knowledge.
Yes, because
Yeah.
this time I think now for COVID-19, some of the dentists still not begin work. If so, during that time, our dentist friend can be take more time to study to know more technology.
Yes, this
Yes.
is true.
Yeah. So now let me to share Dr. screen about the PPT, so we can begin the course. It's time for our course to let our dentist to begin the study.
Okay, thanks, Julie.
Okay, time for you.
Okay. First of all, I would like to thank Coxo Company for their amazing free webinars. And I would like also to thank Dr. Sarah, the sales manager of MCS company, the distributor of Coxo in Egypt. Thanks, Julie, for the excellent organization. I would like to thank Dr. Professor Ahmed Madarati for giving me the chance to be here with this group of international endodontists all over the world. Thanks so much, Dr. Ahmed. Okay, greetings from Egypt. I would like to introduce myself. I'm Dr. Abdulrahman Hamid Al-Kholi, a teaching assistant in Department of Endodontics, South Carolina University, Ismailia, Egypt. And this is my favorite picture of Giza pyramids in Egypt. And this is my university, South Carolina University in Ismailia, Egypt. Okay, and this is my lovely faculty of dentistry. Okay, let's start. Our topic today is the management of difficult root canal anatomy. First of all, this is a journey by virtual roller coaster. Guess why I put this video here in my presentation? Okay. Let's know why I inserted this video here by a virtual roller coaster in this presentation. Let's see. The root canal is like this our calcification. We are here in a straight canal. Straight canal and an isthmus connecting the straight canal with another canal. And finally, there is a canal split into canal, and there is a curvature here. So our root canal is like this. Okay, let's begin. There is an important rule you should know. A straight tapering canal with a single apical foramen is an exception rather than the rule. Okay. Difficult root canal anatomy. I classified difficult root canal anatomy clinically into natural, not affected anatomy, and pathological affected anatomy. Today we will talk about the natural, not affected anatomy, which includes curvatures, Wine's type 4, extra root canals, isthmi and lateral canals, and C-shaped canals. Okay. We will begin with the canal curvature. As I said, a straight tapering canal with a single apical foramen is an exception rather than the rule. Okay, we can classify curved canals into a lot of classifications. One of the simplest classifications are Schneider classification. He classified the curved canals into straight, less than 5 degrees, like this case, moderate from 10 to 20 degrees, like this one, and severe curvature more than 20 degrees, like this one. Okay. How to diagnose a curved canal? Number one, clinically, by the shape of the initial file after the removal from the canal. When you insert the file firstly in the canal, it will take the shape of the canal. It is preferred to be a smaller size file which took the shape of the canal. Okay. Number two, radiographically, by taking a mesial and distal shift or mesial distal angulations, not a single angulation. As you see in this case here, you can see by the cursor here the distal root shorter, okay, by a distal shift. When I talk the mesial shift, oh, it is a very curved root apically. So shift here or multiple angulation is very important in diagnosing the curvatures of the canal. Okay. Also, the cone beam CT here is the best one to identify the curvatures. What are the difficulties in management of curved canals? Difficulties in cleaning and shaping and obturation. As you see here, there are very excellent motors from Coxo. You can use it. Here, an ideal root canal preparation is one in which the original canal morphology is maintained during the preparation procedure. It is a very, very important rule, and it is an objective of your cleaning and shaping procedure. An ideal canal preparation is one in which the original canal morphology is maintained during the preparation procedure. So you must preserve the canal anatomy. Okay. What are the potential risks in management of curved canals? Number one, transportation, as you see here, a ledge, perforation, instrument separation. Okay, let's go to the procedures of management of severely curved canals. Number one, the axis cavity. Your axis cavity must be a straight line axis, to reduce the stresses as much as possible on the files. Okay. Number two, scouting, which means the use of small files passively for scouting without attempting to reach the full working length. Using small files. Do not use large files, as they may cause a ledge. Okay. Third, coronal pre-flaring. It facilitates the direct access into the middle and sometimes the apical canal set. Coronal flaring facilitates the preparation of the remaining of the root canal. Number four, the glide path, which is a very, very, very important step, which means creating of a smooth radicular tunnel from the orifice of the canal to the physiological terminus of the root. It is the most important step here, the glide path. We can do it manually by manual files 10 and 15 and 20, or by rotary files like the pass files from the supply. Okay, the crown down technique, number five, advantages over step back. The crown down technique here is very, very important. When you use the crown down technique, you reduce the stresses on the files. You created a room for the irrigant. You can also increase your tactile sensation, especially in the curved canals. Okay, number six, patency, which is an important step also. Patency means pathing by the file 10 beyond the apex by 1 millimeter after each file to remove debris to avoid blockage. Okay, the motion. The most common motions are rotation and reciprocation. Which is better, rotation or reciprocation? Reciprocation is better as it decreases the cyclic fatigue of the files, improves debris removal, and maintains the root canal anatomy. Number eight, continuous irrigation. The use of continuous irrigation using the sodium hypochlorite and lubricant by the editor gel after each file facilitates the management of curved canals. Do not work in a dry environment. Number nine, the apical size preparation. As we know, in the stainless steel files, when you go larger by the files, the flexibility decreases. Also by the night-eye instruments. When you use large night-eye instrument, the core of the file increases and the flexibility decreases. And the chance for risks such as canal transportation or ledge or perforation increases. So it is recommended that your apical preparation of the curved canal is suitable, not small, not large. How can I justify between the apical preparation and disinfection? In severely curved canals, you can use up to file 30 or 25 with a taper 2 or taper 4. Do not use the taper 6 or the larger tapers that can cause ledges or transportation. So the apical preparation here is minimal. How can I increase the disinfection? You can increase the disinfection by activation of the irrigant, either ultrasonic, sonic, manual dynamic agitation, and so on. Okay? Let's say them all. Number one, the straight line axis, scouting by small files, coronal pre-flaring, glide path, either manually or rotary, the crown down technique, not the step back technique, the patency, the motion, rotation versus reciprocation. Reciprocation, we said it is better, continuous irrigation, and suitable apical size preparation. Okay. Okay. Here we managed the cleaning and shaping procedure for the severely curved canals. What about the obturation? The obturation techniques are cold lateral compaction, warm vertical compaction, and biceramic sealer with single cones. Let's discuss the obturation. What about the cold lateral compaction? Let's see this case. This is my case, which when the post of the year in our excellent group, excellence in endodontics, and when the post of 2020. It was a case of a severely curved canal, mesiobuccal canal. It was very difficult. I used a controlled memory files in a reciprocation motion. Regarding the obturation, using cold lateral compaction by finger spreaders here, the spreader cannot go here. The spreader cannot go here in the curvature. So your master cone here will be alone with the sealer. Okay? What about the warm vertical compaction or the continuous wave of compaction? Your pin, when you cut the master cone and down pack it, cannot go through this curvature and can stop here or stop here. So your master cone already will be alone with the sealer. What about using the biceramic sealer and single cone? As we said, in the cold vertical compaction and continuous wave of compaction or warm vertical, the single cone here will be alone. So it is recommended to use a biceramic sealer here, for better sealing along the cone. Okay? It is recommended to use a biceramic sealer here, as cold lateral compaction and continuous wave of compaction will not seal this part efficiently. Okay? Got it? Okay. It is another case of severely curved wisdom tooth. As you see here, the master cones and the obturation. I followed the steps I mentioned, the 9 steps I mentioned in my slides. It will make the process very easy. Okay. Let's turn to the second object, the root canal classification, Wine's classification, type 1, type 2, type 3, type 4. Type 1 is 1 orifice, 1 canal, and 1 apical foramen. Type 2, 2 orifices, 2 canals, 1 apical foramen. Type 3, 2 separate canals. And type 4, 1 orifice, 1 canal, and 2 apical foramina. The 3 classes, 1 and 2 and 3, are easy to manage. What about type 4, which is our goal? What about it? How can I manage? Wine type 4 can be either like this on the right or the left. The split here is more coronal, which makes the process of cleaning and shaping and obturation easier. Unlike this, which is very difficult, and there is a deep apical split. Okay. How can we manage this case and this case? Difficulties, as we said, in cleaning and shaping and obturation. First, this case, you should remove this dentine ledge. To allow accessibility to the lingual canal. So you must do a coronal flaring to remove this dentine ledge you can negotiate the second canal or the lingual canal. It is much easier than the other case. Okay. Number 2, where there is a deep apical split, how can we manage? This is a very difficult case. Okay, in cleaning and shaping, you can shape one canal, the most straight canal. You can shape this canal, the most straight canal, to the final apical preparation. After this, you can now negotiate the second canal, as the cleaned or the already prepared canal here will guide you to locate the tight, not prepared canal. Okay? Again, we can here prepare a single canal. to the apical preparation. Okay. Secondly, we will negotiate or locate the second canal or the second branch here by pre-curving the file. When it goes in a wider area, it goes in the already prepared canal. When it goes in a tight area, it goes in the other canal. And you can here prepare it manually using manual files for better tactile sensation. Okay, up to the final apical preparation to 30 or 25. Okay, what about obturation? How can I introduce two master cones in these canals? How can I introduce the cones here? You can introduce the master cone of the straight canal here and put a file or the master file or a spreader, as you see in this case, a spreader here, which can maintain the pathway of the canal. Here you will use a taper to get a burka. Here you will use a taper to get a burka here in this region. You will use a taper to get a burka. What about the sealer? Can I use a resin sealer or it is recommended to use a bioceramic sealer? Yeah, it is recommended to use a bioceramic sealer here to seal this area around the file, around the cone, which is a taper to cone. Okay. As you see here, it is a case of a lower first premolar. I forgot to say something. The mesial shift and distal shift here also is very, very important. As you see here, the two files are in the two canals. Okay, the two files here in the mesial shift are in two canals. What about taking a distal shift? You can see here in the distal shift, they are separate canals, not joining canals right here. Okay. I use the technique I told you in the previous slide. I placed the master cone of the straight canal here and a spreader in the other division here and use the bioceramic sealer with a taper to get a burka. Okay, now you can manage the type 4 getter. Here it is another case of vines type 4. You can see here the file is in the straight canal and there is another division. You can see here. Also, I use the same technique. When you use the continuous solvent compaction or the warm vertical compaction, you can put the master cone here and using magnification, you can cut below the split area. You can cut below the split area here and you can put the second master cone here and backfilling the remaining of the canal. Okay, now you can manage either cold lateral compaction or warm vertical compaction or continuous solvent compaction. Okay. The third topic here is the extra roots and the extra root canals. Here you can use the magnification by COXO, microscope by COXO in locating the extra roots and extra root canals. Let's speak about the anterior teeth firstly. The upper anterior teeth, 100% single canal. What about the lower incisors? The lower incisors, 60% type 1 single canal, and about 40% two canals, either type 2 or type 3. So you must know when treating a lower central or lower lateral, there is a 40% of having a second canal, like this. As you can see here, the two canals in type 3 wine configuration. Two separate canals, or like this case, two canals with one apical foramen, one type. Okay. Magnification here is very, very important. Ultrasonics here also is very, very important. What about the premolars? Let's begin with the maxillary premolars. The percentage of having extra roots in maxillary premolars from 0 to 6%, especially the first premolar, maxillary first premolar. How can I diagnose there is an extra root clinically and radiographically? Clinically, when you make the access cavity, you will see that the buccal canal is tight or less wider than the palatal canal, unlike the usual situation. The usual situation you can find the buccal and palatal canal with almost the same width. When you see the buccal canal very tight and the palatal is wide, you can suspect here a third canal. Also, clinically, you will find the file directed towards the mesial or the distal. Upon finishing the access cavity preparation and inserting a file in the buccal canal, you can find or you can notice that the file is directed mesially or distally, which means it is in a mesiobuccal or distobuccal canal. What about radiographically? Radiographically here, when you see, you will notice that the middle portion of the roots here is equal to the width of the crown here, which is not the usual situation in the first premolar. The first premolar, the usual situation, the root is tapering, so it is not wider than the crown. When you see this situation, the middle root of the upper first premolar here is, or the second premolar here, is wider mesiodistally than the crown, you suspect a third root or a third canal. Okay? The third canal will be in the buccal root, either mediobuccal or distobuccal root. Okay. What about extra canals? Can I see extra canals in maxillary first and second premolars? Can you see extra canals, not extra roots? Yeah, we can see here. Here is a case done by me for second premolar. Okay, two overlapping roots. I introduced two files here, one in the palatal and one in the buccal, one in the palatal and one in the buccal. But I see something here. There is something here distally. There is a dentine thickness here. The file is not centered in the root. I introduced the file in the distobuccal canal and there was a third canal, as you see here. Okay? The grasp is very, very important. Multiple angulations also very, very important. Here in the premolars, when there is a third root, you can use a straight view and mesial and distal shifts. What about the mandibular premolars? We talk about the anterior teeth and we talk about the maxillary premolars. Let's talk about the mandibular premolars. Okay. The mandibular premolars have a percentage, a very, very high percentage, especially in Egypt, about 40%, 60% is a single canal. 40% have a second or a third canal. Okay, we can notice here also the apical split, which have 16%, which is a high percentage in Egypt. How can I identify an extra canals in the lower premolars? As you see here, there is a phenomena called the fast break phenomena. As you see here, the shadow of the canal here is continuous, and suddenly it disappears. The disappearance of the shadow of the canal is called the fast break phenomenon. When you see this, you suspect an extra canal. When you see this, you suspect an extra canal. As I said, angulations is very, very important. Taking multiple angulations. Also, a flat apex is an indication of a second canal, as a single canal has a tapered apex. When you see a flat apex, it indicates a second canal. Also, a double lamina dura, like here, you can see double lamina dura here. You can suspect another canal. Non-centralized file, when you put a file and you can see with not centralized, you suspect another canal. A wide mesiodistal, wide root mesiodistally and the shift, as I said. Here is a premolar, lower first premolar, with two separate canals. Here is another case, another very, very interesting case. Lower 4 and 5, first and second premolars, root canal treated with post here, with a periapical lesion here. The patient had chronic periapical abscess. Here, I remove the post and remove the getaburka and find a second canal here. A second separate canal here. You can see two separate canals. What about the lower second premolar? The same. I found a second canal here, as you see. So it is important to know that the lower premolar is very tricky in their anatomy. Okay. What about having a third canal? What about having a third canal? A high percentage also in the lower premolars have a third canal. When you see two canals, suspect a third canal. When you see two canals, suspect a third. When you see one canal, suspect two canals. Okay? Another case like this. As I said, when you see two canals, suspect a third canal. Search for the third one. Okay? As I said, the management in the wine class 4 management. What about the maxillary premolar, the maxillary molar? The maxillary molars. We talk about the anterior, talk about the premolars, and now we will talk about molars. Let's begin with the maxillary premolars regarding the MB2, the second mesiobuccal canal. The second mesiobuccal canal. Concentrate here, please. This is a very important topic. The MB2, the second mesiobuccal canal. We will talk about the incidence, location, the axis, and the radiograph. The incidence of the MB2 or the second mesiobuccal in the first molar is 96%, which is a very high percentage. And in the second molar is about 70%. Also, it is a very high percentage of prevalence of MB2. Okay. What about the location? What about the location of the MB2? The MB2 is located in a mesiopalatal direction to a line drawn between the mesiobuccal one and the palatal canal. When you draw a line between the mesiobuccal and the palatal, you will find the MB2 in a mesiopalatal direction. Okay? As you see here, when you draw a line between the MB1 and the palatal, you will find the MB2 in the mesiopalatal direction. At the end of a coma shape. At the end of a coma shape. Okay? Like you see here. What about the radiograph? What about the radiograph here? In locating the MB2 or identifying the MB2. As you see here, I took a multiple shifts to detect the MB2. Here you can find a flat apex. When you see a flat apex, suspect an extra canal. Okay. Here in a distal shift. What about the mesial shift? The mesial shift here revealed a second canal. But you can see here that the second canal is joining with the MB1. What about a large mesial shift? Here you can see the two canals are separate. Here you can see that the two canals are separate, not joining and not the same canal. Okay. Here is a very interesting case. Very interesting root canal. The master cones. You can see here the master cone of the mesiobuccal is not centralized into the mesiobuccal root. As you can see here, the mesiobuccal root here, the mesiobuccal cone cannot be centralized. You can suspect here a second canal. Okay, it was a very recommended case, and I obturated, and I didn't find the MB2. I didn't find the second mesiobuccal canal. Okay, I didn't find the second mesiobuccal canal, and I know that there is a second mesiobuccal, and I can't get it. Okay, the patient traveled and came after 1 year with this appearance: chronic periapical abscess and a very tender upper first molar. So I knew that the cause is the lost MB2 or the missed MB2. Okay. Here I took a CPCT And I see here the MB1 is obturated, and there is a very, very large lesion here. And there is a shadow of the MB2 here. Okay, what about the distobuccal and palatal canals? The distobuccal and palatal are very good without any periapic catadiophysis. Okay, so I determined my target to retreat the mesobuccal root and find the MB2. I took an hour, I took an hour, 1 hour to locate the MB2. As you see here, the deep troughing here to find the second mesobuccal canal. Okay, here the full working length. Here I removed the getaperca of the MB1. Here the master cones of the two separate canals. Here the obturation. You can see here in this photo the volume of the size of the periapical lesion, as you see here. It was vital. It was vital. The case was vital. Okay. You can see here after 4 months, the lesion healed. You can see here also the lesion here, and you can see here the CBCT scan, the failure and the healing. The failure and the healing. Okay. MB2 is very, very important. Do not miss it. Okay. What about this patient? 82 years old patient. 82 years old patient. Came with a chronic periapical abscess related to the upper first molar. Okay. Under a bridge. I took a CBCT scan after removal of the MB1 of the mesobuccal root. You can see here the mesobuccal 1 and the second mesobuccal canal, and the radiolucency here is located towards the lingual side, towards the MB2. Okay. The distobuccal and palatal are well. Here you can find the second mesobuccal canal. The second mesobuccal canal. The clinical situation, like you see here, this is the MB2. This is the MB2. Okay. Another case of our first and second molars. You can see here the file is not centralized, and there is another root or another lamina dura here in the first molar and the second molar here. You can see another root here. You can see double lamina dura and another root here. The master cones and the obturation. Two separate mesobuccal canals. Two separate mesobuccal canals. Radiographs is very, very important. Okay, another case of separate MB2, as you see here, separate canal in a 15 years old patient. You see how hard was it? And I locate. Okay, another case, retreatment case with a short mesobuccal obturation and a lateral lesion. You can see a lateral lesion. The MB1 opened apically and the MB2 opened laterally, causing the lateral lesion here. You can see the cause of the lateral lesion here is the missing of the second mesobuccal canal. Another case also, separate MB2 here, separate MB2 here, separate, separate, separate. Do not miss the MB2. Always search for it. Always search for the second mesobuccal canal. Here a very, very interesting case. Concentrate, focus with me, please. A very, very interesting case. This is my assistant. This is my assistant in my clinic. Okay. When you see here, you cannot locate every root. Every roots are all the roots are overlapping each other. Okay. When I saw this X-ray, I requested a CBCT scan. Okay. I requested a CBCT. Okay. You can see here on the upper right corner, this is the MB1 and this is the MB2. What about the location of the MB2? or the second mesobuccal canal, second mesobuccal root. They are far away from each other, far away from each other. And this is the distal buccal and the palatal root. Here, when we go apically, they separate. The two roots are separated. Finally, here, mesobuccal root MB1, first mesobuccal root and second mesobuccal root. What about the mesobuccal root anatomy? As you see here, a severely curved root. Severely curved root. This is my assistant. Here the files on the full working length. You can see here the four canals, the MB2, the MB1, the distal buccal, and the palatal. And you can see here the obturation. The severely curved canal was managed well, and the four canals were fully obturated. What about the axis? Oh, you can suspect it is a lower molar, not an upper molar. You can suspect that it is a lower, not an upper molar. You can see here the mesobuccal, the MB1, and the MB2, or the second mesobuccal root, the palatal orifice, and the distal buccal orifice. Okay, this is a very, very interesting case. It was my assessment. What about the mandibular molars? Mandibular molars also have extra roots and extra root canals. We are talking about the extra roots and extra root canals. When you talk about the canals, في lower molars, in lower molars, there is middle mesial canal. We'll talk about the incidence, location, axis, and radiograph. Incidence of middle mesial canal is about from 1 to 15%. So take care, and when you find the mesobuccal and the distal buccal, the mesobuccal and the mesolingual canals are far away from each other, suspect there is a third canal. Okay? When you find that the mesobuccal and mesolingual canals are far away from each other, unlike normal situations, suspect a third canal in between. Okay? Second, the location. It is located between the mesobuccal, as I said, and the mesolingual canal. When you find that the mesobuccal and mesolingual are far away than normal, suspect a third canal. Also, the radiograph also will aid you here, will help you here. The axis, as you see, the radiograph, as you see here. Mostly the middle mesial canal is will be confluent with either with the mesobuccal or the mesolingual canal. It is rare to find the middle mesial canal with a separate apical foramen. Okay, this is another video. What about the middle distal canal? Can I find a middle distal canal or say three canals in the distal root? Yes, you can find them, as you see here. Three distal canals. Mostly the third canal will be confluent with one of the two canals. Okay? Okay. We talked about the extra canals. What about the extra roots in mandibular molars? Radix intomolaris and radix paramolaris. Radix intomolaris means an extra root which is located lingually in the mandibular molars, usually in the distolingual direction. Distolingual root. Usually it will be a distolingual root. What about radix paramolaris? It is an extra root located buccally, usually a mesiobuccal root. Usually a mesiobuccal root. Do not forget that radix intomolaris and radix paramolaris extra roots. Their anatomy, yeah, almostly is very, very difficult. You can find them very, very tight, very calcified. You can see them severely curved. So take care when dealing with these roots. As you see here, this is an extra root, radix intomolaris, extra root, lingually, usually distolingual. This is a case done by me. This root is the radix intomolaris. Another case, a radix intomolaris, before and after retreatment. Before and after retreatment, the radix intomolaris here. Okay. A very, very important point here. The distal canals in the normal situation, the distal canals in the normal situations are closer to each other, are closer to each other. When you see that the distals are far away from each other, suspect an extra root. When you see that the distals of the lower molars are far away from each other, suspect an extra root. As you see here, it is a radix in two molares here. The distals usually are located here, in this point. But here they are far away from each other. Here I suspected an extra root, as you see here, before and after. Another case, the radix paramolaris, which is an extra root buccally, usually in the mesiobuccal. Yes, here. The mesial canals here and the extra root here. Okay. It is a case done by me. Here you can see the root, the extra root with the arrows here. Extra root, yes, here, the extra root, mesiobuccal root here, mesiobuccal root, and the two mesials here with the distal was C-shaped. The distal canal here was C-shaped canal. Okay, another case also, you can see here two separate roots, two separate roots, two separate roots. The separate root is the mesiobuccal root, the mesiobuccal root. The extra root here is the mesiobuccal root. It is a radix paramolaris. Radix paramolaris. Okay. Let's move to the isthmi and the lateral canals, which is a challenge also in treating the lower molars, especially the lower molars. Okay. Isthmi and lateral canals here. You can see. You can see here. Canal, lateral canal. You can see here a lateral canal. You can see here also lateral canal. Let's talk about the prevalence of isthmi. When can I see the isthmus? In which teeth? In C-shaped canals, in the mesial roots of mandibular molars, in the mesial roots of mandibular molars, and the mesial roots of maxillary molar, between the MB1 and the MB2. Okay? Difficulties of cleaning isthmi is the inaccessibility, which is inaccessible by the files, reservoir for bacteria, so it can cause failure if not treated well. This image is very, very important. It reveals the percentage of the touched red points here, the touched areas by the file, and the untouched area, which is colored by the green color. You can see here from 35 to 40% of the root canal is clean and shaped. What about the rest? The rest of the canal, 60%. 60% is not touched. 60% cannot touch. Okay. So you must depend on your irrigation. You must depend on your irrigation. Here, cleaning and shaping, irrigation is the key, and activation. Ultrasonic activation here, or using the ultra smart device from Coxo in the ultrasonic activation. Ultrasonic activation of the irrigant is very, very effective in the acoustic streaming and cavitation or effect of the irrigant, which enhance the antibacterial and the effect of the irrigant. Okay. Activation can be done by sonic activator, by the endo activator, by the and supply, by using air scalers with ED tips, the air scalers with the ED tips. There's a sonic, ultrasonic, as I said, by the Ultra Smart by Coxo, or here by the AirSafe tip from Action, or the file adapter. You can use here the file adapter with the U files. Here the XP Endo Finisher, which is very, very good in expansion inside the canal and cleaning and reaching the irrigant into the isthmi and lateral canals. Very, very effective. Here, the manual dynamic agitation, when you don't have sonic or ultrasonic agitation, or you don't have the experience finisher, you can do the manual dynamic agitation by decreasing 1 millimeter from the master cone and the agitation 100 strokes per minute, up and down. What about the obturation? The obturation of isthmi and lateral canals to be obturated well is done by one vertical compaction, like the obturation system by COXO, or by using the biceramic sealer, which has a high flow and high pi compatible and high bonding strength with the dentine, which can spread well into the isthmi and the lateral canals. Okay. Here a case by me of a lower second molar. You can see here the anastomosis, the isthmus between the canals. Okay. Another one. Here the isthmus is connected between the canals. Here the lateral canals, especially in the lower premolars. Okay. You can see here a lateral lesion, which means there is a lateral canal, lateral lesion, lateral canal. This is the final item of our presentation, the C-shaped canal. C-shaped canal is a complete or incomplete connection between root canals in a ribbon-shaped manner. Okay? C-shaped canal is defined as the complete or incomplete connection between root canals in a ribbon-shaped manner. Complete or incomplete. Okay? We will talk about its incidence, keys included, classification, diagnosis, difficulties, and how to manage. Finally, we'll talk about how to manage C-shaped canals. Incidence of C-shaped canals is about from 3 to 4-5%, especially in the Asians. Okay? These included are the mandibular second molar. The mandibular second molar is the most common tooth having C-shaped canals. Classification, we can Milton classified C-shaped canals into C1, C2, C3, and C4, C5 by the connection between the canals. C1, all the canals are connected here, partially connected, and finally they are here separate. These cases, C-shaped canals. Yes, you can see here communication. C1, full communication between the canal orifices, and here you can see all the orifices in a C-shaped manner, but they are separated from each other. How can I diagnose that this molar has a C-shaped canal? Clinically and radiographically. Okay. Clinically, you will notice that the floor of the pulpit chamber will be lower than normal. When you find the floor of the pulpit chamber lower than normal, suspect there is a C-shaped canal. Also, there is a large amount of bleeding due to the vital tissues found in the connection or the communication between all the canals. Also, you can notice that the instruments will pass from the mesial to the distal without any obstruction when they are completely connected. Okay, you can find when you put your file from the mesial, it can pass to the distal without any obstruction. Okay, clinically. Radiographically, the preoperative radiograph and the intraoperative radiographs. The preoperative radiographs, conventional and CBCT, will reveal the C-shaped canal as follows. Conventional, you can see the instruments tending to converge at the apex. The instruments tending to converge at the apex and may exit at the furcation. You will notice that your instruments can tend to converge at the apex and may exit at the furcation. As you see here in this case, I am preparing and obturating the mesobuccal canal. As you see, the mesial is connecting with the distal. The mesial is connecting with the distal. As you see here, there is a full connection or communication between the canals, like you see here. It's best obturated by ceramic sealer with warm vertical compaction or warm vertical compaction. Okay. Difficulties, I said, in the canal identification. I couldn't find the mesobuccal, the mesolingual, the distal. I cannot locate. They are merging with each other. Also, there is a high incidence of ismi between them. Also, the irregularities between them is very, very difficult to be cleaned and prepared. Okay? How to manage? In cleaning and shaping, you can use the NiFi rotary files, which took the shape of the canal, like the SOCO profiles from COXO. The irrigation activation is very, very important here, as you will depend mainly on the irrigation and disinfection of these or such canals by the means I said, sonic, ultrasonic, manual dynamic agitation. And finally, you can use intracanal medication to help in the cleaning process, as the files and the irrigation may need extra disinfection by the canal and by the intracanal medication. Okay, the management of obturation of the C-shaped canals, as I said, by the warm vertical compaction technique, which adapts to the canal irregularities, the softened gataberca adapt well to the canal irregularities, or by using the bioceramic sealer with either single cones with the warm vertical compaction. The bioceramic sealer with single cones or with warm vertical compaction. Thanks so much. Sorry for my duration. I took a lot of time. It's turn to Julie.
Thank you
Sorry
so
for
much,
that.
Dr. Abdurrahman. Really
Thanks, Dr.
very
Sarah.
interesting lecture
Thanks,
and
thanks so much.
amazing cases. Congratulations for all these amazing cases, really.
Thanks
Uh,
so much, Dr.
as a
Sarah.
dentist, it was a lot of fun to watch this lecture.
Thanks so much, Dr. Sarah.
Yeah, I see that
Any
many
questions?
comments say very excellent case.
Yes, there are a couple of questions from Dr. Amra Haggag. He was wondering about
And
the final irrigation protocol for vital and necrotic cases.
Dr. Sarah, about the question, I will show in the screen one by one to answer,
Okay.
and then please help me
Okay.
to read the question, and then Professor help me to answer the question. Now I checking the question. Wait a minute.
Okay.
First is this.
The final
Yes.
irrigation protocol for vital and necrotic cases. Okay. For vital cases, I use the sodium hypochlorite, 2.5%, then followed by saline, followed by 17% EDTA, followed by 2.5% hypochlorite with activation of all of them. In necrotic cases, I add the chlorhexidine in as a final irrigant, final rinse. Okay.
Okay,
Yeah.
and then this is the second one.
Do you prefer ultrasonics in curved canal sear? No, I don't prefer them. I prefer using the ED tips. The ED tips is flexible tips that can adapt to the curved canals well and activate the area. Ultrasonic can cause leakages. You can use the AirSafe, but the AirSafe is has the problem of easily broken by
Mhm.
the when application. So I recommend using the sonic activation by the editor.
And this I don't know what they write because not English.
No, they are inviting their friends to watch the webinar.
Yeah.
Okay, and
Thanks.
then let me check some more question. Wait a minute.
One of our viewers said that you are more of an inspector than a dentist.
Okay, and this.
This is my professor, Dr. Nasr Rashad. And he is laughing with me. Thanks
Yeah.
دكتور نصر. Thanks. بعدين يا دكتور نصر. ماشي. Another question.
Okay. I think this the same is say something well like that,
Okay.
right?
My friend
Yes,
Muhammad.
you have a lot of
So,
supporters in this
Yeah,
webinar.
I see so many supporters.
شكرا يا صبر. شكرا يا صبور. حبيبي.
And this,
Sir, can you elaborate more on irrigation protocol? I said irrigation after each file. You can notice that in the manual
hello.
preparation or manual, you can use about you can see here. You can see me.
Yeah, not so good just now. Okay,
Okay.
now it's
Okay.
okay.
And the manual technique, manual cleaning and shaping techniques, you irrigate after each
Hello.
file. Hello? Can you hear
Yeah,
me?
just now not so good.
Sorry. Sorry, I'm sorry. Sorry for interruption.
Yeah.
Now the rotary instrumentation, you use a lower number of files and the amount of irrigant decreases. Okay, so it is recommended to use up to 5 millimeters, up to 5 milliliters of irrigation after each file to increase or to compensate for the low irrigations used in the manual files. And the activation is very, very necessary here to increase the effect of the irrigant. Okay, so irrigate after each file and activation in the finer gens.
I think Dr. Sarah know that well, right?
Yeah, now irrigation
Yeah,
is very important, really.
Yeah, as
yeah.
I know, irrigation really very important. How about
What
this
is the
sealer?
best buy ceramic sealer? A lot of sealers here in the market, but I prefer to use a Cerasil from Meta. It is has high flow with reasonable cost. Also, the Bi-C sealer from Angelus is very, very good.
Dr. Sarah, you used what kind of the sealer before?
I'm not an endodontist, really. I'm a
Oh, okay.
protodontist.
So in your country, is it different? Even for dentists, they have a different fund. For some is for endodontist, some is for different, right?
Yes, of
But
course, we have
Yeah.
in
also
China, most
specialties.
is for all. Okay, let me see. Any question more? I think this is the last
Okay.
question.
What
Brown
about
blue.
weld
What's
root?
that be?
I didn't use it, but I will try it and send you the feedback.
Yeah, maybe later
Okay.
you can answer this in comment for this.
Okay.
Okay, so
Next.
thank you so much for tonight. Join our course.
Thanks, Julie. Thanks so much.
Thank you, Dr. Abdurrahman. It was an honor, really, to attend this lecture. And
Thanks.
for all our friends who attended from Egypt, I just want to tell them again that MCS Masr Sina is the agent for COXO here in Egypt, and we are offering a lot of offers now. And also, Dr. Abdurrahman, during his lecture, he mentioned magnification and how it is important. And really, I think magnification now is very important in identifying any extra canals or
Extra.
missed canals. I think it's very important. And now we have COXO dental microscope. So I think it will be very, very beneficial to use microscopes in such cases, like cases that you showed us.
Okay.
Yeah, so
Yeah.
now I show the photo of MCS. If any dentist in each they inquire our coastal product, you can contact MCS.
Okay. This is one of the best companies in Egypt. Really.
Yeah, yes,
Yeah.
thank you so
Thank you,
much.
Dr. Abdulrahman. Thank you.
Thank you, Dr. Sarah.
Thank you.
Thank
Okay, so tonight is finished for this course. Thank you all of you, and then thank you to take your time tonight. About this
thank
later, I
you.
will explain for comment the with certificate link.
Okay. Dr. Jose.
Yeah, so I will share the name for everyone later, and then to get our certificate. So later, if the dentist friend want to get our course certificate, please to see our comment to fill the link with the name and the email. Then can get our course certificate in about 5 days.
Okay.
Okay,
Great.
thank you so much for all
Thank
Thanks.
you. Thank
Thanks.
tonight.
you.
Thanks,
Okay,
Julie.
Bye bye.
Thanks.
goodbye
Thank
Bye
you.
bye.
everyone.
Bye.
Goodbye.
Bye.
Bye.
Thank you. Bye.
Okay, so let me introduce of next course next week. Our next week the course is from Spanish. Next week Wednesday again. This is our Professor Dr. Joes from Spanish. So the same day is Wednesday. So welcome everyone to join with our course free public webinar again. So hope to see everyone next time. Goodbye, everyone. Goodbye.